So I'm Dr. Harish Kancharla, currently working at Yashoda Hospitals, Somajiguda, not Secunderabad. So, so in the next 20 minutes, I'll be taking you through the variety of therapies have been approved in breast cancer. Focus will be on early breast cancer. So we all know that any cancer patient has to go through a sequence of surgery, chemotherapy, radiation therapy, and in the last 10 years, 2 or 2 decades, there is a lot of development thanks to the technology and the better understanding of the disease. We have evolved so much, and there are so many new medications have come into the practice, like targeted therapy, immunotherapy, and they're all based on the make better outcomes for the patients with the help of the newer technologies to understand the biology of the disease. I can say, if I take the breast cancer here, so breast cancer, all breast cancers not are the same, irrespective of the stage. We have to divide them into hormone positive breast cancer, HER2 positive breast cancer, and triple negative breast cancer. Here, my focus is on HER2 positive breast cancer because all three of them have different way of approach in terms of sequencing of the treatment, or in terms of the adjuvant therapy, in terms of follow-ups also, and in terms of the type of treatment we use. So we divide breast cancer into three based on clearly on ISC. We have to advise each and every breast cancer patient before starting the treatment. So that is HER2 positive disease is based on the ISC. If required, some patient requires FISH to test or confirm whether they are HER2 positive or not. And we can do more broader testing sometimes in a metastatic cases, where we can do the amplification and gene enrichment with genomic arrays also, which will predict the response to the therapy. And we can also check for the tumor infiltrating lymphocytes on the histological specimen, which will guide us whether the therapy is going to give the best benefit to the patient. So it's all individualized and more of precision medicine these days. We have to follow the newer methodologies to divide the patients, to stratify them, to give the best outcomes. So there's a neoadjuvant chemotherapy is a standard of care for most of the breast cancer patients, barring some of the hormone positive breast cancer patients. We have to sequence with a neoadjuvant therapy. There's a therapy administered prior to the surgery, which will address a lot of issues, especially micrometastasis. Any tumor more than 2 centimeter or any node positive disease in a breast cancer patient, they tend to have micrometastasis already reached to some parts of the body, even they're not evident on the scan. So it allows the early treatment of this micrometastasis, which is not visible on the scan. We think that tumor is there only in the breast on the scan, so why to give therapy? So even these cells being a microscopic, they don't not visible on the scan. So that we have to understand to divide them as per ISC and take them for the neoadjuvant therapy even before the surgery. So one more advantage is to downstage the breast cancer. So it is always important to get a surgery which is cosmetically feasible. Some females, of course, because of the many issues, they want a conservative surgery. No need to remove the entire breast. If you give the prior chemotherapy or targeted therapy prior to surgery, we can shrink the tumor and you can convert the total mastectomy to breast conservation surgery. So it's always to preserve the breast, we can remove only the tumor itself. And downstage the axilla, again, some patients, you must have seen some cancer patients who underwent mastectomy coming with a single limb, having a lot of edema. So this is very cumbersome to have a lot of lymphedema. So we can save some of the patients if you give chemotherapy prior, and we can reduce the axillary burden. We can get away with axillary lymph node dissection with this SLNB. So some patients, it will also give us idea about the responsiveness to the therapy and biological nature of the individual patient itself. So for that, we take a marker after completion of treatment, that is pathological complete response. So after giving the neoadjuvant therapy prior to the surgery, so once you go for the surgery, once you take out the sample, for histological specimen, we check for the pathological complete response. That means none of the cancer cells left in the specimen. So we do achieve greater responses in HER2 positive and triple negative breast cancer patients, especially if we have given the right treatment prior to the surgery. Pathological complete response, when there is no disease left in the specimen, which will tell us how long he can live than compared to who doesn't achieve the pathological complete response. So this is because the relapse will occur sooner or later when compared to the patient who achieved PCR because of more drug resistant clones. You have given therapy and patient achieved complete response even with the therapy. That is, there are more of sensitive clones. Someone still having leftover disease even after your best effort, the resistant clones, they tend to relapse and then to reduce the survival outcomes. So there are several meta-analyses advocating this PCR marker, a complete response on histopathological specimen, which will indirectly tell us these patients are going to live longer. So that is survival outcomes, event-free survival or old survival. If you combine all these trials, we get clear evidence that we can simply use this early endpoint to give the best suggestion to the patients in the clinic.